Good morning, everyone. I'm getting a lot of feedback. I don't know if anyone else is. I'm Dr. Vikas Sani of the Lown Institute, and today we're doing a webinar which will focus on RightCare Rounds. We have three presenters, Dr. David Bohr, Dr. Brandon Combs, and Dr. Harry Cho. The concept of RightCare Rounds is a really exciting one. We're attempting to recast a long-standing practice in the medical community to new purposes for the emerging world of healthcare and health. As part of our broader efforts to do this, we're pleased to announce that the Institute is now accepting applications for its first class of the RightCare Educator Program. The program supports chief residents with training and support to implement RightCare Rounds in their home institutions. As you'll hear today, several institutions have implemented rounds, and now we're looking for a group of young leaders to further refine the program as we grow it nationally. So we hope you'll consider applying and also share this information with all of your colleagues. The application deadline is June 30th, and the application is available on the Lown Institute website. The requirements are a commitment to implement RightCare Rounds on a monthly basis, participation in a web-based training program which will be held in the late summer or early fall, and participation in quarterly conference calls with a final brief program evaluation. All chief residents and ACGME accredited training programs in the United States are eligible. So without further ado, let's move on to RightCare Rounds with Dr. David Bohr. Thank you for joining us.
Thanks so much. So I'm David Bohr. I'm sorry you're seeing a blue version of me, frozen in time. I'm talking from Cambridge, Massachusetts, and I want to talk about my experiments here with RightCare Rounds. And I'm going to tell two brief stories. One, the rounds that we called avoiding avoidable care rounds, and then how we left that to come to something we're calling RightCare Rounds. About 3 years ago, I decided that I would ask each of the heads of the divisions in my department to present a rounds, much like the Choosing Wisely campaign. I asked each to come up with the top five avoidable diagnostic tests or therapeutics in their area, and to present them with evidence to the department. And it was really interesting to me. They came up with very local and idiosyncratic ideas that didn't necessarily find their way to the national Choosing Wisely campaign. For example, there were many supplements, dietary supplements used in our area for weight loss and for muscle building, which were dangerous. There were many people using anticonvulsant levels as a way to guide anticonvulsant use, a lot of testosterone use, and so on. I found this interesting, and some of the ideas ended up being hardwired into our computer to avoid or to warn physicians about ordering testosterone levels and so on. But the audience did not find this engaging, and they were a little bit annoyed that we were talking about avoiding care rather than providing care to patients in the safety net. And they were more concerned with problems of underinsurance, with access, difficulties, and social determinants of health. So I reformatted the rounds, now calling them RightCare Rounds, and instead of taking this top-down approach, I used a bottom-up approach. And I used this template, which I'm going to show you. Which I hope you can see. Can you see?
Hey, Dr. Bohr, we can't see your slide right now, so can you try screen sharing one more time?
That should have worked.
Dr. Moore, if you can continue talking, I'll do my best to get your slide up
Okay, that
again.
would be great. So I used a template, which hopefully you'll see soon, to guide the conversation about the process of medical care. And I will give a quick example of a case presentation that helped us to guide the conversation. The idea here was that the audience would provide the solution. We'd present the case, and we'd use this template as a way to, there it goes. We'd use the template as a way to guide conversation. So here is a case. Mr. A was a 60-year-old cab driver who was disabled by alcoholism and advanced COPD. He was admitted to the hospital with chest pain of uncertain duration. Because of his inebriation, it was very hard to get a detailed history, but we later discovered that he had had 3 cardiac catheterizations in the past 3 months at 3 other area hospitals. We learned that his medical expenses exceeded $100,000. During our hospitalization, he withdrew from alcohol, regained his pulmonary function, the chest pain resolved, and he was discharged. But we were very curious about what was the story behind the story. And I then went to kidnap him, to find him at an anticoagulation visit, to ask him about the story behind the story. How did he decide to come to the hospital? And he told me the following story. He said, the yellow house is the key. If he can't walk past the yellow house up on the hill, he knows he needs help. And when he needs help, he calls a friend, his AA sponsor, and the AA sponsor calls an ambulance. So I asked, why does he call the ambulance? And he said, oh, because he's an EMT. He uses ambulances. And thus he ends up in the hospital. And I said, well, when you're in the hospital, are you discharged? He said, no. Once I'm in the emergency room, I decide where I'm going to go. If it's cold outside and I want a good meal, I usually go to psychiatry. And if I'm looking for company, then I go to medicine. I said, well, who decides? He said, I decide. How do you decide? He said, well, if I want to go to medicine, I tell him I'm having chest pain. And if I want to go to psychiatry, I tell him I'm having hallucinosis. So we presented this case to the department. And the 2 ideas that came out of the department were, one, why not bring his AA sponsor into the circle of care and let him guide the phone call? And the second was maybe the patient should be enrolled in an elder service program. And you can imagine there are elder service programs here that provide more support and care. The point of all of this is that, as you can see in this slide, we can talk about diagnosis and talk about opportunities to avoid unnecessary diagnostic tests. We can talk about our failure to prognosticate with patients. We can talk about opportunities to avoid treatment or to find better treatment. We often forget to look at the locus of care and how people enter the system. Do they use ambulances? Do they use phone calls and the like? Do they have access? Do they have insurance? And what we also often neglect, which we put in the center of the slide, is the patient's preferences. The preferences about whether to use diagnostic tests, how to use them, whether to have a diagnosis, and what would be the meaning. The patient's preference about or informing the patient about prognosis and treatment opportunities. Again, what are the patient's preferences around treatment? And in this case, the big issue was who determines the locus of care? Does the patient? Do we? Does the system? Does somebody else? And is that locus determined by patient's needs or patient's aspirations? So I think in the end, the RightCare Rounds, what we've done is use the case method. We've used this template to mainly as a guide, like a checklist, to be more complete in thinking about medical care. and we've engaged the audience to come up with the solutions. This has been pretty successful, and I'm formatting our morbidity and mortality conferences as RightCare Rounds. Though I should say my colleagues here call them Right to Healthcare Rounds. So that's a Cambridge story at a safety net hospital. And I will now turn to the next in line, who I think is Harry?
It's actually Brandon. It's going to be me.
Brandon.
Hi, everybody, and thanks, Dr. Bohr, for that introduction. I hope that my slides are projecting okay. Thanks to the Lown Institute for hosting this webinar, and thanks to the online guests who are joining us today. When I first heard about RightCare Rounds from Vikas, this concept of providing right care for the patient, considering the whole patient and the entire continuum of care, I immediately thought this is an amazing opportunity to tell patient stories. And telling stories about overuse and the harms that can come from it is something that we've been doing pretty regularly at the University of Colorado since 2012, when we started the Do No Harm Project, which is a program relying on narrative medicine where trainees are asked to write clinical vignettes describing harm from medical overuse or too much medicine. Our goal with this program has been to raise awareness around the harms of overuse, changing the conversation locally about what it means to provide right care, and ultimately changing culture and doing better for our patients. In the end, I viewed this as an opportunity to share the stories as we had with the Do No Harm Project, but within a different venue, and in this case, a conference format. Since carefully describing stories of harm from overuse was something that was familiar at Colorado, certainly within the internal medicine program, this felt very doable to us. We had existing space within our divisional Grand Round series, but there's no reason that morning reports or noon conferences couldn't accommodate something like this. We wanted to be very careful to frame this whole exercise as a tool to provide the best possible care for patients, to not be judgmental, to not point fingers. We wanted to have a conference akin to a morbidity and mortality conference and provide an opportunity to engage a group of experts to come up with solutions for challenging cases. In addition to recognizing overuse and changing behavior, we wanted to zoom out and focus on the bigger picture. We wanted to pay careful attention to the patient's unique circumstances. For example, maybe a lack of housing was a driver of overuse, and also to reiterate the importance, as Dr. Bohr pointed out, the patient preferences in the decision-making process. We also felt it would be useful to introduce an EBM component, moving beyond qualitative statements of something being better or worse than another, and really quantifying more precisely the pros and the cons of relevant medical interventions. Finally, we wanted to consider the drivers of medical overuse in a formal way, showing the many ways that it can occur and identifying ways to overcome it. So let me walk you through what we did and how you might do something similar in your institution. First, find a good speaker, and it can be a resident, it could be a faculty member, it could be a medical student. If you're a nursing student or you're with a nursing school, it could be faculty or trainees there. It doesn't really matter, but the key is that the speaker should be enthusiastic and energetic. And then you have to advertise. Let people know that, you know, we're doing something different. These conferences that we've been doing forever, these are very important, but we're going to try something else now, and this isn't your average conference. What we're going to do this time is consider a case of harm or near harm from medical overuse, and we want to better understand how it happened and how we can prevent it going forward. Something to pay attention to is that since overuse, despite being all around us, can be very hard to spot, you should keep your ear to the ground for good cases. And it happened that when we did our first one at Colorado, I was familiar with a case that one of our new faculty had submitted to the Do No Harm Project when he was a resident and subsequently had published in the Teachable Moments series in JAMA Internal Medicine. So let's look at the basic format then. So the first thing that we do is present the basic outline of the case. And so I'm going to walk you through the case that we presented initially of a middle-aged man who had a history of depression, chronic low back pain that was treated with opioid medication, and very poor social support, who had, over the previous few months, developed debilitating fatigue and erectile dysfunction. In the course of his evaluation, low testosterone, or low T, was discovered, and he was instituted on testosterone replacement. Unfortunately, replacement with injectable testosterone led to significant mood swings. But in speaking with the patient, he said, look, my quality of life is paramount. And, you know, these medications, I know that you guys aren't crazy about them, but they're helping me. The opioids are helping my pain, and the testosterone is helping with my fatigue and my erectile dysfunction. And, of course, the cultural context here is this ever-present request from the makers of testosterone to ask your doctor, could my symptoms be due to low T? The next thing that we do is we engage the group. We pause here for a moment after introducing the basic outline of the case, and we say, you know, this is challenging, and what do you normally do? How do you manage someone like him, somebody with fatigue and erectile dysfunction that has hypogonadism, and they're started on the medication, and they're also on chronic opioids for low back pain? What do you do? What resources do you draw on to manage patients like this? What challenges do you face? And we just have a lively discussion that way. The next thing that we do is we then identify, the presenter identifies the instance of overuse. And ideally this will be an example that's common but challenging. And so we were able to deal with the bugaboo of chronic opioids and replacing low testosterone all at once. The next step, in addition to just identifying the instance of overuse, is to back it up with some evidence to convince the audience that the intervention that you're suggesting was overuse, unneeded or unwanted, that the evidence would actually back that up. And so in this case, what was suggested was that that he was prescribed a medication, testosterone, for the side effect of a potentially avoidable medication, that is, the opioid for his chronic low back pain. Then we asked the speaker to quantify the benefits and the harms of these interventions. And so I'm not going to go into the nitty-gritty details here, but the summary of opioids for chronic low back pain and for testosterone for the replacement of hypogonadism in middle-aged men, particularly when it's induced by another medication, the benefits are probably oversold, and the risks of these interventions have been minimized. The next thing that we do that's really unique is that we identify and discuss the drivers of overuse in a very formal, systematic way, using what we call the RightCare Fishbone. And so many of you will be familiar with the usual cause and effect diagram used in M&M conferences and quality improvement type conferences, where an error is often the outcome to be avoided. You'll notice that in our conception, overuse is the outcome to be avoided because it can only lead to patient harm. And you see here the 5 major categories in bold that we identified, that we considered in our conference, and then solicited individual drivers from within these from the audience. Now, this isn't meant to provide an exhaustive list, but rather to provide a systematic framework to help an audience consider the drivers of medical overuse. And boy, does this really promote active discussion. And so let's have a look at these one by one just to wrap your head around them. So if you focus on the top left of this figure, we talked about industry factors. And so this is particularly a big issue with both chronic opioids as well as testosterone replacement. There's this constant onslaught of some new branded medication for the treatment of pain or some testosterone preparation for the treatment of hypogonadism. And then look at clinical factors. And so a common one here is preference misdiagnosis. Often as clinicians, we diagnose illnesses and we get the right treatments, but we may not apply it to the right patient because we may not fully understand the patient's preferences. And so a preference misdiagnosis can occur when a fully informed patient would have actually declined, say in this case, treatment of his back pain with opioids, had he understood the downsides of the opioids, or perhaps he would have declined use of testosterone had he understood the risks inherent to the use of testosterone. Down on the left, at the bottom there, clinician factors, diagnostic uncertainty, that's a big one. When clinicians aren't sure, how do I diagnose or how do I think about fatigue and erectile dysfunction in a middle-aged man? What are the right labs to order? Is it a testosterone level? This can lead to overuse. What about the economic forces? And so supply-sensitive treatment is a big one. And if you just Google low T center, you'll see that there's ample opportunity to go have your symptoms evaluated at a low T center and get your treatment promptly. Finally, the patient factors. What's the patient support network? How are they coping with their illness? And patients, not everybody, but oftentimes we have coached our patients to rely on a, quote, medical solution. rather than the reality that treatment of low back pain and probably intermixed depression and fatigue and so forth, that may rely really on some sort of psychosocial solution. The third step of our conference is to suggest an alternative approach. And this is where we suggest, how can we do better next time? Based on what we now know about the evidence, based on what we know about the patient, having spoken with them and diagnosing their preferences properly, what could we do differently next time? What evidence supports this? What are the guidelines that are out there that we can draw on to further refine our practice? And then to reflect, is there any opportunity for system change here? A QI type of approach. Is there something we can change locally to provide better care for our patients going forward? And so I'll just talk briefly about some barriers to RightCare rounds. Look, these are common, these are real, these are things we hear about all the time. Wait, who's in charge of this? What is RightCare rounds? Why do we need to do something different? Who's going to present this? Why do this? Where are we going to do it? We don't have time for this. And so expect those kinds of questions potentially, but it's not a big deal. This can be overcome. And this is why you need a passionate champion to drive this process. Look, overuse is common. The issue with overuse is that it's hard to recognize. You will not have a short supply of cases if you can get people thinking about this and speaking a common language around it. A nice incentive here is that you can uncover quality improvement opportunities locally to change care, to provide better care for your patients. And be flexible. And so if people say, we don't know if we have the right venue, I would argue that yes, you probably do. Because remember, noon conference, morning report, grand rounds, M&M conferences, preclinical conferences, there are all these existing educational time slots that are perfect for conferences like this. Finally, lessons that we learned, faculty and house staff are very engaged in this. They're very interested in this, and people are craving this kind of conference and these kinds of discussions. I would advocate for using existing educational time slots. Don't try to create something altogether new. Just drop this into a space that already exists. And these stories that we're telling, these are much more than just anecdotes. The patient stories are powerful, they're memorable, and really they provide a scaffold for the evidence. This is one way that trainees learn to practice medicine. So next steps, a few possibilities that I've been thinking about. I wonder about moving this from the inpatient setting to the outpatient setting in a preclinical conference. I wonder about taking this out of the clinical setting entirely and having students participate in this, maybe after a clinical experience where they can meet with a faculty facilitator, for example, or even a chief resident or a senior resident. What about bringing the patient and sharing their perspective? We're working with our quality improvement chief here at the University of Colorado to have a recurrent noon conference dedicated to RightCare rounds. And then, of course, as Vikas mentioned at the beginning, be sure to check out the RightCare rounds educator program for rising chief residents, which is meant to help chief residents implement RightCare rounds at their institution. So thanks so much for listening. That's the Colorado perspective. What I'm going to do now is pass it along to my colleague, Dr. Harry Cho, who's at Mount Sinai, and he's going to tell you about a really interesting conference that he's running called Occams Conference.
All right, thanks, Brandon. Okay, so let me just bring this up here. Okay, so my name is Harry Cho. I'm the Director of Quality and Patient Safety at Mount Sinai Hospital. I'm a hospitalist here, and ours is very similar to the RightCare rounds, with a few things that are different. But it's called Occams Conference, and so it's named after William of Occam, who's a 13th century theologian, logician, and philosopher. And I think we best know him from our medical school days, where he came up with this thing called the Occams Razor, which is a principle of parsimony, economy, and succinctness used in problem solving. So when you hear hoofbeats, think horses and not zebras. And I think this is sort of good guidance in terms of minimizing overuse. And it's an acronym, like how most things are. So overuse, clinical case morbidity, and mortality. We snuck that second A in there. And there's two parts of this. So first part is the case conference, and the second part is the work group. And the case conference is very similar to the RightCare rounds. The first part is the case itself. Again, at Mount Sinai, we treat overuse as a medical error, and so we wanted to focus on the cases of overuse that led to an adverse event or a near miss. And the adverse event can be very broad. It can include financial harm, emotional harm, and many other things. Within our team, we have a dedicated social worker, and anyone can really do this. It's to get the patient-centered perspective So we either talk with the patient or talk to them over the phone, and we get a full financial history. These are questions like, what type of insurance do you have? Who are how many medical providers do you go to? How much money do you spend on medications per month? And we share it with the group, and we focus on the value and cost teaching points. These are very important because, again, this is for residents and students, and so frontline providers do need ammunition to sort of talk with the other providers and with their patients. The next part is the root cause analysis in the brainstorming session. We can go into detail in a little bit. So there's 3 people needed here. The presenters, the first one is the moderator, and this is sort of the key person, sort of helps guide the conference itself. And you want a safe atmosphere. You want to make sure that no one is dominating or pressing one way or the other. You want to make sure there isn't any kind of accusations. We want a sort of a good atmosphere for people to discuss the issues. The case presenter, we like to have it as a resident or student. And it's very brief. Usually we limit it to 10 minutes at most. And then there's a recorder to sort of document the root cause analysis that's being performed in the brainstorming session. And the audience, like I said, is the house staff and students. And this is our Fishbone. Brandon shared his. We have, so again, the focus of all this is to look at the adverse event as a medical error. And we look at the drivers of overuse. And we sort of picked and chosen a few of these. But a lot of these Brandon sort of went over. And then the bottom is the classic Fishbone used in quality improvement, which is the systems-based issues. So we go through this, and it sort of works out well. People take apart the case to individual pieces, and then ideas start popping up. And then we do a brainstorming session with everyone and about how to sort of prevent this from happening again and harming a patient. Now, the second part of this is a much bigger part. It's the Occams work group. So the focus here is to work on the value and safety improvement projects that stem from the case conference itself. And the whole goal is to make sure that that case of adverse event doesn't ever happen again. We do this monthly. We have a data analyst, which is very helpful and very important for this to sort of move forward. And we invite house staff and medical students, and they've been key parts of sort of making the projects and driving it forward. Okay, so we find that this really works well, this combination. So why does it work? Well, I wanted to share with you the story of the learning platform. So this is a story a while back. There was a man who was working on an oil rig in the deep Atlantic Ocean, and he was sleeping, and he was woken up one night by a large thunderous sound, and it sounded like an explosion. So he got out of bed, he ran over to the ledge, and he realized that it was a big explosion and a fire that was all around him. And so he was just trying to figure out what to do. So he looked around, he looked to his left, and there was this fire that was fast approaching him, and then he backed away and he looked to his right, and again the fire was encroaching upon him. And so he had nowhere else to go, so he looked downwards, and it was 100 feet into the freezing waters of the North Atlantic. And so he looked to his left, he looked to his right, and he had nowhere to go, so he took the jump. And he went in the ocean, he lost consciousness, but shortly after, a rescue boat came and picked him up, and they warmed him up, and he woke up. And they asked him the question, hey, so why did you end up jumping? And this is the question. It's this sense of urgency. It's the key driving factor in terms of moving initiatives forward. It's the fire that gets set upon that people sort of want to rally behind. So this is a picture of a brain. This is the right side and the left side. So the right side, I like to think of it as sort of your math geek. This is the logical part, the numbers, the linear, the system analytic part of you. And then the left side, I think of it as sort of the hippie artist, the artistic, creative, colorful, emotional part of us. And we have this inside each one of us. And it's important that we sort of tap into both whenever we sort of get people to get excited about something. And the audience itself is residents and students. And I think about this, and it's been working so well. And there's a lot of interaction. And I feel like there's no better crowd. Trainees are underworked. They're overworked. They're underpaid. When you're in this state, they crave efficiency, and they just really despise wasteful things, especially when it harms a patient. And so it builds up this sort of nice burning platform. And this is the Icahn diagram. So in the 60s, there was a man who was overseeing quality in the shipyards of Kawasaki, and he sort of popularized this tool, the root cause analysis, the Fishbone diagram, and so it works so well. It raised it to a new standard, and it sort of went from quality improvement in the shipyards to cars and everywhere else, the business service, and now it's in the healthcare. And most hospitals now have an RCA group to sort of work on medical errors. And we find that it really works well here. This is from Gosby's book, Human Factors Engineering for Improving Patient Safety. And it's sort of a way to sort of look at the effectiveness of some of these error reduction strategies. And at the top, you have all those forcing functions and automation and computerization. And at the bottom is a couple things that I sort of pointed to there. It's the education, information, and exhortation, which is just basically telling someone, be careful, okay? Think about it more. And, you know, there's, having a lot of background in quality and safety, there's not a single initiative that I do that doesn't involve a ton of education and sort of reinforcement. But in order to make change happen, in order to create a sustainable safety or prevention of errors, we have to do, I think it's important that we have to focus on other things in addition to education and information. And as much as I want you guys to remember this this webinar and my talk and Occams Conference and everything else, at the end of the day, we're going to forget about 90% of this, and in 2 weeks from now, you're going to remember maybe about 1% of this. And so we need something extra to sort of drive this forward. I'm going to skip over this one. And so, in effect, it's an interesting sort of machine that this is running. You know, you have the case that a resident brings in because something happened with his patient, and a case of overuse that they found frustrating that actually harmed the patient, and you sort of talk about it. You know, you draw it out in detail, you get the patient's perspective, and then you sort of, you know, and people sort of contribute, other people who are in the team, including social workers and multidisciplinary folk, and we talk about it, and then we talk about the teaching points about what's evidence-based and what's not, how much does this cost, and then we go through the root cause analysis with the residents and students, and it breaks it down into little pieces, and people sort of put those together, and then they come up with some brainstorming strategies about how to prevent this. It goes to the work group, which is sort of well run with a data analyst, and we try to create a process that's a sustainable process and sort of led by frontline providers. And so it works out well, where you have an in and an out and a good product. Okay, so I have the slide up, and this is from Daniel Wolfson from a few months ago. It's regarding this Choosing Wisely recommendation. So, you know, Choosing Wisely is in its 4th year, and at first it was there to sort of create an awareness of overuse and in relationship to harm. And, you know, at first when I started giving these talks, I would sort of ask, I'd ask people to raise their hands if they sort of heard of Choosing Wisely, and at first very few people knew about it, but now virtually everyone is raising their hands, and I think the awareness is definitely out there. But as Daniel Wolfson put it, the opportunity may lie in sort of how to best implement these recommendations in practice and creating deployment strategies. So in terms of implementation, how do we do it? Where do we move the needle? How do we effectively get a sustainable process to make these improvements? And so in terms of, you know, our Occams Conference, so in terms of just some caution, finding cases, Brandon sort of outlined it very well. Sometimes it can be tough to find some of these cases, and you have to be proactive about it. I think the benefit that we have is that it is sort of a working machine, so that whenever people give us cases, something will be done to it, done about it, to prevent it from happening again. And so there's a little bit more of a motivational factor to give us some cases. The other thing that I wanted to mention is the burnout of the group. Now, it is co-chaired by 2 attendings who does have a background in QI. I help oversee the process, and we do have residents there to sort of come and help and get involved in some of these. But the burnout is real. I mean, it's essentially a project every month. So we work on a few models here. The effort impact model is very important for us. So we want to create, you know, it's the low-hanging fruit. We want to capture the most impact, create the most impact for the least amount of effort. And so we have to figure out good strategies to do that. The second thing we do is we keep these transparent. So every month we sort of create an outline of where we are in some of these projects, and we have this ABC model, and you can name it whichever way you choose. But So the A model would probably be the smallest project. This could be just a simple educational program that you just go around, do grand rounds in front of the residents and maybe in front of the hospice or a set of specialists. Whereas the C model is a complete project. It could be getting baseline data, full retrospective, going through multiple PDSA cycles and trying to implement change there. And the resources, they can be limited. Just like anywhere else, we have our EMR system, and whenever we want to create changes there, it takes months for it to get through. But some things that we do have that are helpful is the data analyst, and we do have an epidemiologist and a statistician that can help with a lot of our work. That's been very helpful. Just want to thank Lown Institute for awarding us with the RightCare Young Innovator Grant. It's been very helpful for us in terms of making sure that this runs very smoothly. And just recently, we won the Teaching Value and Choosing Wisely Challenge from Casa and the ABN Foundation. And this is the extensive team, and they've been very helpful. And I just want to give a quick shout out to them. And thank you.
Great. Thank you so much to all of our presenters today. So we did have a question that came up during Brandon's presentation. It came from Stephanie, and she asked if anyone has actually tried this approach with hospitalists walking rounds. I guess this can go out to anybody, but she specifically asked this during your presentation.
I wonder what aspect in particular. Is it use of a fishbone kind of analysis on rounds, or some other aspect?
I think she did ask during that portion of your presentation, if I remember correctly.
It's not something that we have done, although, I mean, certainly not in a formal way. I think we do it informally when we observe overuse on rounds, for example, and we brainstorm what happened here. I wonder what really was the principal motivator, the principal cause of overuse in this instance. And so I think we do that, but I think it could be potentially richer if we identify an instance of overuse, if we could break out or memorize something like an overuse fishbone, so to speak, and run through that with the team, or maybe do that after rounds, for example. So I have not done it personally. Maybe Harry or David have some other thoughts on that, but I think it certainly could be done. I think that's a great idea.
Yeah, I agree with you. I'm a hospitalist, so I do these rounds all the time. Occasionally, we pick apart a few sort of things that happen. For example, the overnight admission, where there's a whole bunch of testing and treatment done that we felt, in hindsight, was not necessary, and so we go over a couple drivers of overuse. We say something like supply-sensitive treatment, where that MRI machine is very readily available, and this is probably why they got it very quickly. We do have some spot discussions there.
I've never used a structure like that, but in typical notes, when one gets in a SOAP note, when one gets to the assessment, they typically write diagnostic interventions and therapeutic interventions, and it could be that before one gets to diagnosis and therapy, using some kind of guide, you could put in all the drivers, the industrial drivers, clinical, patient, economic, I don't remember the clinician's drivers, or however, some easy way to remember, or you're using your Occams. But I think on the after that assessment, on the plan, I would love to see people write diagnostic plan, therapeutic plan, prognostic plan. How are you going to explain, and what is the data you need to be able to come up with a prognosis? And I'd also love to see somebody put in locus of care as part of the plan. Where should this person get their care now, in the future, and so on. So I think we could restructure the SOAP notes and the typical notes in a way that would use some of what we've all contributed as kind of reminders. You don't want to make it too complicated. The nice thing about SOAP is it's 4 letters long.
Love that aspect of it.
Yeah, it's just interesting, David. We had a discussion not long ago about, so we have residents who, we call it the MAR, the medical admitting resident, who sort of triages, and whenever the ED says admit a patient, they sort of go through the history, have a little short discussion, and then they triage them to the right area, to the right level of care with us, to step down the ICU to a teaching unit or to a non-teaching unit or to surgical units. And we had a brief discussion with some of the night docs who do the admissions to have a little discussion, a little short teaching point about prognosis and whether a patient with pneumonia, based on a CURB 65 score, whether they actually need to be admitted or can they go to the obs unit or can they just go home. But it's a great thought there.
You know, I've had some experience trying to rewrite the SOAP note in the simple way I wanted to convert it into a scope note, where the C is the patient's concern. So after subjective, let's at least every day ask the patient what is their concern for the day. And there was a kind of unanimous support. It was a great idea. And 2 days later, it was completely forgotten by everyone. And I even had it written into the standard template in our electronic medical record, and somehow it's disappeared over time. So it's pretty hard to change behavior. It's pretty hard to change culture unless we keep it pretty simple.
Right. That could be a great idea for RightCare Action Week, a scope note. What's the patient's concern?
Well, it does put the patient in the middle of our concerns, which is where the patient should be.
Right.
Absolutely.
Great. Thank you guys so much for your presentations and for answering these questions. Brandon, you brought up a great point about possibly using that for RightCare Action Week. So for all those who haven't quite heard of RightCare Action Week just yet, if you go to our website, rightcareactionweek.org, you'll learn more about it and how we're hoping during that week we can take action in order to raise awareness about the complexities of the healthcare system and how we can make things better. So a scope note during that week hopefully will do the task. So once again, thank you very much to our presenters, Drs. David Bohr, Brandon Combs, and Harry Cho. And we hope everyone was able to learn a lot about RightCare Rounds. And please stay tuned for more webinars in the future. Just go to our website, louninstitute.org, to learn more and to keep updated with what's going on in our work. So thank you very much and have a great afternoon.
Thanks, everybody.
Thank you.
Carissa.